Our session, State of the Sector, sponsored by Exponential Triage, is beginning now in the session room.
Good morning, everyone. Thank you for joining us today. I'm Daniel Schoenbrunn, CEO of Exponential. We are the leading AI admissions tool, and we are, I'm going to say very proudly, partnering with leading SNF operators to drive a wave of innovation. I'm sure you're hearing a lot about what's coming out there. I got to tell you, it is real and is happening now. Exponential Triage helps you evaluate and win the best referrals before your competition even has a chance to open the second page of the PDF. And this is just the beginning. We're building an entire suite of high ROI tools that also improve quality of care. Just if we could give a moment to one of my favorite customers, Steven Dubinsky, he'll share a few words, and then we're going to get to the main event.
So Exponential has helped us take our facility that we trialed them out. We started with them, we were at 65% census. The system was not, functioning very well. Response times could be up to an hour. And over the last year with Exponential, I wouldn't say they're the only reason, but they certainly have been a key factor in bringing the facility up to an over 85% census, 15% skilled, and response times are now 5 minutes or less. There's no lag. Bringing a one-stop, from the offender checks to the eligibility, the clinical appropriateness, it's done in a second, and it really has been a game.
Thank you so much, Stephen.
Thank you.
Absolutely. So if anyone's interested in learning more, just to make it easy for you, we're passing around a sheet. You can leave your quick contact information. I look forward to meeting you, whether to talk about triage or any of your other ideas about how AI can help. Like, we're here to listen, we're here to partner. There's really quite a lot to do. And without any further ado, it's an honor to introduce Cliff, who is really a shining light as it relates to innovation, improving care in post-acute.
All right, well, good morning, everybody. I hope you're well and enjoying this balmy weather. I'm not sure where in the country you're coming from, but I guarantee you it is not as nice as it is here right now. So the timing of eCap couldn't be better. I think it was 8 degrees in DC, which is completely unheard of for us. And there were a couple of readings that I think it said that one night we were colder than Antarctica, which was like, are you serious? And they were like, yeah, look, in Antarctica was this. And I was like, wow, this is a switch. But anyhow, it's a pleasure as always to be here. I want to thank the folks at eCap, as always, for being a leader and hosting this meeting. It's a great opportunity for all of us to connect, reconnect, talk, discuss issues, because all of us are flying around in so many different directions. And I don't know about you, but I really do often appreciate just the ability to be in people's presence and be able to sit down and have a cup of coffee and give somebody a hug or dap them up, whatever you do. But it's always a pleasure to do that, and this particular conference gives us a unique opportunity to have those kinds of relationships. It's a great time in long-term care. I'm going to talk a bit with you today, more or less about where the sector is. I want to start with the fact that I'm incredibly optimistic about where things are and where things are heading as a sector. As many of you may know, I've been in the sector now for 36 years. I started at 22 years old, and as an AIT and CNA in college, and then AIT, and then ultimately administrator, and sort of worked through operations for about the first 15 years of those 36 years. And often we talked about, and one of the reasons, frankly, I chose this as a profession was, I needed a job, right? It was pretty simple. And I was really trying to think about, not just a job, but more importantly, what would be a good career to be engaged with. And I had an uncle who was a hospital administrator, and I thought I wanted to be a hospital administrator. That was sort of my initial vision for my life. And he connected me with a hospital CEO and let me be his volunteer gopher for a week, and I hated it. I just thought, this is a bunch of crap he's doing. He's running around talking to doctors. He never talks to patients. What is this all about? And I just wasn't excited about it. And then I stumbled upon long-term care as an option, and I'll never forget the graphs talking about, the aging boom, and, at that time, all these nursing homes were being built in America. This infrastructure is being constructed in America, and it would be a great place to essentially start your career. That was a wise decision for a 22-year-old. I never thought I'd be where I am today, frankly, but more importantly, I never thought I'd be in a position to make a difference as I am today. And I think the one thing that I want to encourage all of you is that one thing hasn't changed about this business. It's always hard. It's just hard. It's hard for a variety of reasons. We're serving folks that have high care needs and oftentimes represented by families that feel like they've betrayed their loved one by making this decision for them, and they feel like they failed, and it's basically up to us to make a very, very tough and difficult life season as meaningful and as tolerable as possible. And that is a very, very tough situation. And when you combine that with an overly zealous regulatory construct, again, I'm pro-regulation, we need it. I've got parents that are in facilities or were in facilities, they need to be protected, but we have a system that doesn't serve that end very well at the moment. And then obviously we need to make sure that we have the resources necessary to take care of patients and meet society's expectations for delivering care. So when I think about the sector overall, there are a lot of positive things going on. I'm going to talk about those. I'm going to talk a bit about some of the things that are changing that I think are important for you to understand and to recognize, because we are in the midst of fundamental change, change in payment, change in how we view quality. We're going from a we used to call it value-based payment, and you used to think about fee-for-service payments separate from capitated payments and all these other structures. Well, even fee-for-service is changing, and we're going to be moving to what we call fee-for-value. It's not fee-for-service, it's fee-for-value. And even in that scenario, we're seeing some changes at CMMI that are starting to test those concepts. So thinking about traditional PDPM in the way that we always have, that's even changing. So we've got a lot going on, a lot of change, but there are a few things that are consistent, and I think are the kinds of things that ultimately bode well for all of us. So let's start with industry trends. I want to start with some NIC data that I think is really important to see, and this covers every sphere of senior housing. So if you look at independent living specifically, we're at about 89.1%, and it's up 40 basis points from the previous quarter. Independent living, 90.6%. Senior housing rather than independent living, another, again, 40 basis point increase from the previous quarter. If you look at assisted living, it's up 60 basis points from the previous quarter, and then even in the SNF world, it's up 20 basis points. So every sphere within aging services, particularly in housing, be it assisted living, be it independent living, be it SNF care, we're seeing significant growth. Census levels in all of those varied portions of the continuum are above pre-pandemic levels, and you can see the curve, and I always call that the hook that you see is the COVID hook, but we're seeing just explosive growth, and I think that pitch that you see in that graph is just going to continue upward. So what does that ultimately mean? It means that demand is up, and demand will continue to grow, and I'll talk about that in a second. The tough part for us is, and continues to be, generating a qualified workforce to care for all of these folks. I fundamentally believe that this is the existential issue for our sector forever. It's not building capacity, it's not policy, it's where are we going to find the people to actually deliver the care and service that this exploding population needs. And there is not one answer, and frankly, there is no answer from Washington, D.C. We can talk about immigration reform and all that stuff. We could open up the borders and it still wouldn't solve the problem. The growth is that fast. And then you compound that with what other countries are doing and having the same challenges in their countries and developing their workforce to deal with the growth in the particular senior population in their own country. So we've just got challenges worldwide, systemic, sociological challenges in our country as it relates to caregivers for the future. The reality is we have far more folks that are aging over 80 than we do have people being born. You know, I don't know about you. I say it in speeches all the time. I mean, my daughter was born when I was 24. Me and my wife got started young. I was born when my dad was 24. My dad was born when his mom was 17. She was born when her mom was 18. She was born when her mom was 16. So you can get some perspective on this gap that we're seeing and this delay, if you will, in having children. I have a daughter, my oldest daughter. She's finally working on having a child. I'm excited about it. I pulled my son-in-law aside over the holiday, and I put my arm around him and said, I never thought I'd be having this conversation with another man, but what can I do to help you out, brother? I'll be your wingman, whatever it needs. Whatever you need to do, y'all need to get away. Look, I'll pay for it, you know. I'm like, what am I doing? Like, this is ridiculous. This is my girl, you know. But this is how desperate Cliff is for grandchildren. But he's a great guy. I wouldn't do it otherwise. But the reality is we just have some systemic changes. And part of that is just, I just call it the function of privilege. I mean, our country's better. We're all doing better. We want our children to do better. They don't start their lives, and a lot of times, you know, with that, they kind of got a little bit of a head start. And so what did they do? Like my daughter and her husband did. The first 5 years of their marriage, they traveled and they enjoyed each other, which I think is fantastic. And frankly, I'm envious a little bit. I didn't have that luxury. And maybe I would have made a different decision. But you know, when you're broke and you're married, having babies is free entertainment. And it's great entertainment, it's free. And that was about all we could afford. So, but there's a reality here that we're seeing throughout, you know, our country, frankly. And we're still 26,500 workers below pre-pandemic levels. Now, if you go back again, census is above pre-pandemic levels. Workforce is below pre-pandemic levels. What does that mean? There is a greater delta between our census and the number of employees serving them. There are less people serving more people than we had before the pandemic. And that fundamentally is not changing. Now, what we are seeing today, and this still still holds true. I've been through, as an administrator in operations, I think I was through 2 recessions in my career. The first one was the post-dot-com recession during the Clinton years, earlier in my career. And then there was one a little bit later in my career. And the one thing that I will say is that we all experience improvement in our workforce during recessions because people want to keep their jobs and they want to be in a field when people are basically laying folks off that is somewhat recession-proof. Healthcare is recession-proof, and what we're ultimately seeing is some moderation and growth in our workforce. Report just came out from BLS today, I think it was in the news on the headline, that basically said the only sector in America that's actually growing is healthcare. And that's a traditional, common shift during recessions. I always say recessions are good for long-term care. We got to fight over rate and budgets, but it absolutely helps on the workforce front. But the reality is that we hope that we're not in a extended recessions, and recessions hopefully don't last long. And then we kind of get back to where we were before, which is a growing economy and essentially trying to combat and fight to keep the workers we have. Now, this is the most exciting slide when we look at the macro environment that I like to show. And right now, we are in 2026, so between 2025 and 2030, there'll be 4 million more people over the age of 80. 80 is the key age cohort for care needs. 75 technically is the year where you begin to have, at least statistically, more encounters with the healthcare system. 80, you have lots more. Most of your healthcare dollar is spent post 80. My dad, in assisted living today, has been healthy his entire life. 3 years ago, he has a stroke, a fairly massive one, and it's just been healthcare, just constantly. And this isn't necessarily uncommon. And now he's 83, and obviously is encountering this. But here's the other thing. I mean, we're going to see another 4 million between 2030 and 2035, another 4 million between 2035 and 2040, another 2 million between 40 and 45, and then basically over the next I guess that's 35 years, 15 million more people over the age of 80. Statistics show that about 20% of those people are going to need and touch our system at some point. So the reality is we do not have enough capacity today physically to handle this. We don't. We've had contraction as a result of COVID, of the actual bed availability in our country, particularly in rural areas. The rural areas, it's like 15% worse. It's bad. So depending on where you are in the country, these again are dealing with averages, but the reality is we just don't have the capacity to care for folks. And most importantly, we don't have the people to do so. So there are a lot of things that we need to be thinking about. I like this graph because I think this is a much more sort of relevant view as it relates to the future workforce. And what you'll see here is the top line is what we call a combined ratio of workers. And this is effectively the ratio of workers per 80-year-old based on age cohort. So overall workforce, so you'll see here that the overall workforce is the blue line. The gray line is 45 to 64-year-olds. Those are what I would call older workers. And then you have the black line, which is our sweet spot, which is the 18 to 45-year-old. The 18 to 45-year-olds are a really important age cohort. Why? Because I call them the strong back, strong knee generation. They're the ones that are going to be lifting and turning and have the strength to do the things that our particular industry requires. And here's a mortifying statistic when you think about it. Today, there is roughly 8.29 18 to 45-year-olds for every 80-year-old, okay? By 2030, that drops to 6.59. By 2035, just 10 years, it drops to 5.41. And then if you go to 2050, and I'm particularly interested in 2047 because that's when I turn 80, it's half. We will have half the 18 to 45-year-olds available to work to serve 80-plus-year-olds in our country by 2050 than we do today. That is mortifying. Now, granted, some of these older folks are going to be strong like me, and they'll still be working, and they'll help moderate some of that demand or need. And then I think technology will also have some impact on that, and hopefully efficiencies, et cetera. But I'm telling you, I've been at this a long time. I kind of chuckle sometimes. I've been at this a really long time. You can't get away from needing people. Not in our business. We are a people business. And this growth is so explosive that while technology will delay and moderate, while efficiencies will delay and moderate, while policy changes will delay and moderate, the wave is so crazily overwhelming that we have a very, very real challenge. And I'm convinced as a country, like we have to have Marshall Plan mindset. I mean, we're talking about big thinking, big investments, big strategy around what we're going to do about this. Because if we don't, we're going to have real problems. The days, I always say, when I talk about this phenomena, my father, I talked about my grandmother and all that and those generations, I knew that. Because why do I know those ages? They all lived together in the same house in Georgetown, Washington, D.C. My dad grew up with his mother, his grandmother, and his great-grandparents, all in the same house. Everybody had a job, and the job was to take care of the great-grandparents. He had a job at 14 to walk grandpa, great-grandpa to the store and back. Everybody took care of everybody. And obviously, the economy was quite different in that women had fewer career opportunities, so they were mainly focused at the home as well. So we don't live in that society anymore. It's over. It's over. Women are bosses, and everybody's a boss, and so everybody's working. Everybody's doing what needs to be done and taking advantage of opportunities today in America. So the reality is that we got a real problem. Now, I want to shift a little bit to one of my favorite topics, and I say that sarcastically a little bit, but Medicare Advantage has been a real challenge, obviously, for our operators. And it's really interesting. I'm, pretty what I would say, naturally fiscally conservative. It's just my mindset. Maybe it's because my granddad was born in 1910 and raised during the Depression. He lived through the Depression, so he taught me, you got to be fiscally conservative. That's a story for another day. But I fundamentally do believe that markets do handle and take care of problems, inefficiencies. I think markets do that on their own. Some would disagree with that. I think government has a role in that, but obviously I think it has a very heavy-handed role in our space, too heavy a hand in our space, frankly. And one of the areas has to do with Medicare Advantage. But what is interesting is in 2026 is projected, and we saw a decline and a peak in 2024, where we're seeing a shrinking in the Medicare Advantage marketplace, meaning plans are getting out of markets. And we saw a precipitous drop between 2025 and 2026. So what we're effectively seeing now is a contraction of MA plans in particular marketplaces and their availability in particular marketplaces. And this particular graph shows HMOs, PPOs, a variety of different plans that are out there. But you can see that number is going down. What is absolutely fascinating and surprised me was this particular graph. And what you're seeing is year-over-year growth between Medicare and Medicare Advantage. So what this essentially means is how many more folks got into the Medicare program in our country, what percentage of them were Medicare fee-for-service as we know it, or Medicare Advantage. When you look at the last 5 years, and frankly you could go back a decade, usually what we saw is explosive growth in Medicare Advantage and actual deterioration or decline in Medicare fee-for-service. Okay, so you have people trading in Medicare fee-for-service, getting Medicare Advantage, and a precipitous decline in Medicare fee-for-service and an explosive growth in Medicare Advantage. For the first time last year, we actually saw a 200,000 person growth in Medicare fee-for-service. We've not seen that. I don't know when we saw that last. So we're actually seeing people choose Medicare fee-for-service over Medicare Advantage. Some of it's a function of there's not a plan available, right? So if markets are shrinking and plans are shrinking, right, then they don't have the ability necessarily to, more or less service patients in those markets. So plan was here, now they're gone, I got to switch back to fee-for-service because I don't have any other options. So some of that is a factor. Some of it's just decision making. And I've said it and I'll say it again, there's a significant amount, and we have one of our major priorities with our Better Way agenda is to reaffirm the promise of Medicare Advantage. And that is our focus, because the reality is beneficiaries are the ones that ultimately suffer if the plans are not administered fairly. And what does that mean? What that means is, you hear a lot about it now, prior authorization. You hear a lot about utilization review issues. All these things matter. And why do they matter? Because it's a hassle. And I'll say it myself. I've done it on behalf of my family. I have become the de facto case manager for anybody that I know. And I'm getting more and more calls about that. But, in caring for my own dad, and I'm an expert, right? I know you ain't going to exhaust me. I know who to call. But it is exhausting. It is absolutely exhausting fighting every 2 and 3 days to get my dad care or get my uncle care on the telephone, talking with the therapist, sitting on a group call, looking at the chart, making sure that this is being communicated so that we can ensure that my dad gets care. That's from an expert that is fully cognitively aware and strong. 85-year-olds don't have the energy to do that on behalf of their loved one. So they exhaust them to the point of giving up. And unfortunately, that's a problem and fundamentally has to change. So we're going to be working on that. Now, let's talk a little bit about the future, and I alluded to it earlier in the presentation, and that was this concept of fee-for-service to fee-for-value. One of the best, greatest accomplishments, if you will, and you could argue politically about the Affordable Care Act. Just so you all know, in DC parlance, if you say it's the Affordable Care Act, you're a Democrat. If you say it's Obamacare, you're a Republican. President Obama liked Obamacare better. He liked to own it. I use the formal name, not based on any political predilection, but it is funny to hear people, splice words like that. But one of the phenomenal inventions, if you will, from the Affordable Care Act was this Center for Medicare and Medicaid Innovation. And I call it a payment quality laboratory. And it's essentially this sub-agency that is allowed to just issue waivers and just try things different, track the data. They don't need all the authority you normally need to do things. They have a lot more liberty to experiment with different ideas. And I just think that's fundamentally important, particularly as we are in this explosive change within our healthcare system. And there are a few developments that I think are important to note. There are a variety of things that were just announced by CMMI as it relates to different payment models going forward. Team, Ahead, Maha Elevate, and Lead all have implications for long-term care. Team and Ahead I'm going to talk about in a minute because those are the ones that I think have the most direct impact on long-term care. And then there's these other models that affect other aspects of the healthcare system, but I want to elaborate more on this. Teams. Essentially, a Teams model is what I'll call a bundle payment model that's held by the hospital that effectively looks at certain diagnoses and requires that the hospital manage the cost within that particular diagnostic bundle. And the episodic payment, you can see here, has to have a hospitalization and has to be managed for 30 days after discharge. After 30 days, it kicks into whatever the traditional structure is. But this is pretty significant, and there are, I think, 80 or so CBSAs, regions of the country where this is going to be toyed with. But it is important because it underscores, and I think it's going to continue. I could elaborate more, and I'll do it in another speech, but we learned through the staffing mandate how much more we are, and particularly from an outreach and advocacy perspective, we are collaborating, we're like arm in arm with the hospitals, right? Because we find that we live in the same ecosystem and have become quite interdependent. We used to fight with the hospitals. Early in my career, you fought with them about stuff all the time. I don't want to tell them anything, and it was always a fight. Not anymore. This is a very collaborative kind of relationship, and I think that will continue. And again, as it relates to the individual markets that you're in, there's nothing more important that you can do than develop strong relationships with your local hospital partners. This is one of the reasons. Okay, quality is going to be incredibly important. Patient outcomes are going to be incredibly important. Spending for those particular diagnoses is going to be incredibly important. Rehospitalization is incredibly important. All these things are important, and obviously there are practices that you implement for other reasons with other partners, but this is a reality that I do not think is going away. If you get this particular presentation, you can click. We got a toolkit to help with this available to our members. And then we also have a participant list as it relates to what markets this plan will be rolled out. Now, Ahead effectively is a state-based total cost of care model that provides funding to build infrastructure and create systems that can have capitated-like payments. Essentially what that means is it's more of an infrastructure kind of grant that can be used to help these individual markets sort of build the systems to integrate to be able to ultimately deliver budgets that incorporate primary care all the way through to long-term care. So those are the two big areas. And again, there are others. We also have the former REACH program that's having and undergoing some change as well. Most of it's, I think it's positive changes. They're refining it and going to extend the program for another 10 years. So just a lot of opportunity. And I think the opportunity and what really excites me is that providers can actually partner with and create their own plans and share in the savings. And every and anybody that I've spoken to that actually has an iSNP has seen significant benefit. And if you think about it, there's just significant alignment because it is in the best interest of the owner of the plan, the provider of the care, that that patient stay well, stay out of the hospital and stay well. So investments are made to keep people well. When I go to a SNF, I am going to join an iSNP, period. That's my plan. I'm going to sign up. I'm signing up. I'm going to tell my kids, like, when my time comes and I got those last couple of years, if I have to deal with institutionalization of some sort, I want to be in an iSNP because everyone is incentivized to ensure that I am as healthy as I possibly can be considering the circumstances. So lots of exciting things on payment models. Again, we need to just start thinking about, if we think that PDPM payments as they stand is going on forever, forget it. That's not the case. That will change, and there will be some value expectations around those payments as well. All right, let's talk about the association, and I want to talk a bit about our agenda. I don't know. I'm just giving you some real cliff speak here. I fundamentally believe, it's probably based on the fact I started as an operator, we have to get results. I don't like talking about, we got to do stuff, and we have to accomplish things. And this particular agenda, I think, artfully lays out exactly the direction that we need to head as a sector. Our board has provided not only the strategy, but the resources to actually accomplish these goals. So we have 4 buckets I just want to make sure you're aware of. The first is workforce. Obviously, we have to strengthen the workforce. What does that mean? We have to advance policies that elevate the watermark for everybody. That's all we can do. We've got to advance policies that ultimately ensure that there are additional, more workers, more opportunity, more education available to bring more workers into healthcare to serve our patients. Again, the most impactful effect that can be had is what you do as an operator. You've got to have the best place in your marketplace to work. You've got to have great benefits. You've got to have competitive pay. You got to be kind and loving and make your folks feel like they're part of a team. You got to do all that work. There's nothing I can do for you when it comes to that. But we can do things and advance policies that actually help increase the supply of workers. Second, I talked about already reaffirming the promise of Medicare Advantage. I'm not going to get into that anymore. The third is my favorite, which we're deeming and terming rationalizing the regulatory environment. We are not saying repeal regulations. Look, I've been in this business for 36 years. And if folks don't want to give good care, if folks aren't checking on patients, if folks aren't providing the care that patients need, they shouldn't be in the business, period. Do not be in the business. This is not there are a lot easier ways to make money. I got friends that are in banking. I'm like, can you let's go play golf? I don't have time to play golf with you. I got to work, I got work to do. They want to play golf every week, every Friday, Thursday, like Thursday through Sunday. It's like, dude, do you have a life? What are you doing? I got to work. But the reality is that, again, it's hard, but we've got to rationalize this regulatory environment. We have a regulatory environment that doesn't protect patients. It undermines quality. It fundamentally undermines quality. There are components that protect patients, but the reality is it absolutely undermines quality. We have to change that. And then lastly, we have to provide support to our state execs in our individual states at the local level with Medicaid. The big Medicaid fight already happened last year, and we were as successful as we could be by getting a carve out or insulation for long-term care on the provider tax cuts. We were the only sector in all of healthcare to actually be carved out and protected on provider taxes. There was no other sector. That's never happened before. I'm really proud of that. But the reality is it's a watermark, at least in my view, that our efforts over the years are actually beginning to break through. Policymakers understand that we're different. Policymakers understand what the demand is, and policymakers ultimately understand that we are underfunded. So now that we got them to understand that and not cut us, we got to get them to understand it and better reimburse us. That's the next level, and we'll get there. Workforce, I'm not going to get too much about it, but these are the 4 different areas that we're focused on. Again, pipeline, tech, training, recruitment. This is the important thing, and these are 5 pieces of legislation we're very focused on that actually do have an impact. Healthcare Workforce Resilience Act deals with visas. Ensuring seniors access to quality care act is what we call the CNA lockout bill, which allows us to do more training of our nursing assistants in our facilities, and there are a variety of other pieces of legislation here that will actually have an impact on workforce. None of them singularly will solve the problem. This is a battle of 1,000 fronts. We're just going to go at it every way we can. And this is a start, and I think we'll actually have some impact. Medicare Advantage, we talked about. I'm not going to get into some of the disadvantages of Medicare Advantage. But again, we have this deny and delay tactic I spoke about earlier. We also have this issue of prior authorization and even retroactive denials after care is delivered. It's been approved, delivered, and then they do an audit and want to take the money back. That's got to stop. And then again, we've got to really look at the costs associated with these plans. And I think you're seeing it over and over again: increased scrutiny, increased criticism, and I think a much clearer understanding from policymakers of what's going on with these MA plans, and more importantly, how they're impacting beneficiaries. And we want to help fix that. And then this goes through some of the solutions. Again, we want medical professionals, not AI or algorithms making decisions about care. I need to talk to a person when it comes to my loved one, and I need a person making this decision. I need a human being telling me why my uncle, who's falling every day still, and this is a real example, and has syncope, and you're trying to send him home from therapy. Well, he's falling every day. We got to fix the falling, or he'll be back to the hospital, and that will be done. That's just dumb. But these are the kind of things we have to, and you can't have that argument with ChatGPT. You got to talk to a human being to actually deal with these kinds of things. And then, again, we got to have market competition, ensuring that there's fair market competition there. So we do have legislation as well introduced for Medicare Advantage, one dealing with prompt pay. Deliver a service, you should be paid in a certain amount of time. Second, fair pay, meaning we should be paid a rate, and there should be a floor on that rate to ensure that we are adequately reimbursed, consistent with Medicare fee-for-service. And then lastly is the Improving Seniors Timely Access to Care Act, which is more about dealing with issues relating to denials and ensuring that essentially there's not these prior authorizations that are preventing people from getting the care they need. They should be able to get the care they need just because they medically deem it necessary. Rationalizing regulatory environment, I could go on and on and on and on. I'm not. I could speak a day about this, but the reality is this: the current system is inconsistent and ineffective. The current system undermines quality. The current system is a amalgamation of rules from 1965 to today. There are rules and regs that have existed before I was born. They are still on the books before I was born. The 3-day stay is one of them. That existed since 1965. How dumb. I mean, just think about it. How much has our system changed since 1965? That having a 3-day gatekeeper is somehow, it's insanity. But we've got a variety of and we've done a lot in this regard. Key examples of things is that we got to update the 5-star system. We're making progress there. Risk-based surveys are a big push. As I wrap up, I'm excited about risk-based surveys. Essentially what it says is if you've got great quality, you've got consistent quality, you shouldn't have the same intent survey. You should have what we call survey light. Come in, check your systems, just like you do with the doctor when you get a physical. I'm healthy. He checks the main thing. I go home, right? That ought to be the same process for facilities. CMPs, we've already made progress there as it relates to access. So that's kind of a win. And then obviously, we got to strengthen the special focus facility program with an effort to get people off the list, not an effort to get them on. So we got to kind of change that mindset. This is a long list already in 2025 of some of the wins on the agenda. I'm not going to go through that. We talked about Medicaid. We got to help our states fight that battle. And we're doing that through a variety of different ways as a national association to support our states by providing them resources and grants from essentially the national entity to help them fight these individual battles as they arise. I have, you should come, let me just say this. You should come to the Quality Summit. And I'm not going to tell you why, but we're going to have a really important guest speaker that's coming. And this person is really, really important in our regulatory, I'm giving you hints, in our regulatory world as well as our payment world. And they're a very well-known person. So I encourage you to come. They're gonna come and speak. And the only reason I'm not announcing it yet is because we're like, they agreed, but we gotta nail down one additional detail. But it's really gonna be an important opportunity for us to have a really exciting quality summit. And then we've got our Population Health Management Summit. It talks about all those things that I mentioned relating to Medicare Advantage, special plans, ISNPs, these teams models, and some of these other things. If you're interested in understanding the direction that payment is going in long-term care, particularly, that's the summit you need to be at. It'll all be in Baltimore, Maryland. So I am done, and I am over 40 seconds. But I absolutely appreciate everything you guys do. And if anybody, I don't know, one or two questions, I'll be glad to answer them if you have them. You can ask me anything you want. Doesn't matter to me. Say again? Yeah, I'm around. Holla at your boy. All right. I'm here. That's my guy right there, actually. Yes, sir. Oh, not you. All right. Well, look, it looks like nobody has questions. Thank you. Have a great conference.